The first one is dermal filler. And I'm sure everyone is very well aware how dermal filler is extensively used in patients who are menopause. Dermal filler are basically products injected within or beneath the skin to improve its physical features by soft tissue augmentation. It restores volume in cheeks, temples, and jawline. There are several types of dermal filler. It can be autologous, which can be fat or cultured human fibroblasts, collagen, which can either be bovine-derived or human-derived, or the most commonly used would be HA or hyaluronic acid. So the hyaluronic acid can either be a non-animal stabilized or a viscoelastic HA from bacterial fermentation. Dermal filler can also be synthetic or pseudo-synthetic implants as mentioned here. So this is a case of a patient who have had several problems post-menopausal. You can actually see here on the picture on the left, there is a volume loss in the mid-face, deepening of the nasolabial fold, as well as a markedly seen tear trough deformity. Okay. After filler has been given, you can see here that the nasolabial fold has been markedly improved together with the tear trough deformity. The cheek also appears to be more prominent. So an overall feature would show that the patient would be more rejuvenated. The next one is botulinum toxin. Okay. Toxin basically works by reducing dynamic wrinkles and fine lines. And toxin produces temporary chemical denervation by blocking the presynaptic release of acetylcholine at the neuromuscular junction. The usual duration of effect for toxin is 3 to 6 months with individual variation. So some of the common wrinkles that I see in my practice would be the glabellar wrinkle. This is due to the contraction of the procerus and the corrugator muscles, and also the crow's feet, which is due to the contractions of the orbicularis oculi. After injections of toxin, you can see the patient has a much more relaxed features. The next treatment, which is the in thing currently in Malaysia, is injectable skin rejuvenation or skin booster. The goal of skin bio-rejuvenation is to increase the biosynthetic capacity of fibroblasts, inducing the reconstruction of an optimal physiologic environment, enhancement of cell activity, hydration, and of course, synthesis of collagen, elastin, and HA. So the way it's being done is by doing micro-injections in the superficial dermis of products containing only one active ingredient or maybe cocktails of different compounds, which are perfectly biocompatible and totally absorbable. So the compound can be HA, vitamins, minerals, nutrients, hormones, growth factor, amino acids, and even fibroblasts. So this is one of my patients who, prior to having skin booster injection, you can see here that the patient has an uneven skin tone, dull skin, and also very tired looking features. But after only one session of HA skin booster, you can see the patient has a much more glowy and radiant face, smoother in texture, and much more even in tone, with a brighter and fresher complexion. The good thing about skin booster is that it gives you the natural look. The patient doesn't look like it's done, and it gives you the effect very immediately as well. The next treatment, which has been in the market for quite a while, is microneedling. So microneedling is basically rows of fine needles which are rolled or applied over the skin to create rapidly healing punctures. This will then create wound healing response, which will then result in collagen and elastin production. Microneedling also allows transdermal drug delivery through pores created through the stratum corneum. So besides treating aesthetic medicine, not just for postmenopause, we also do microneedling for dermatological problems such as keloids. Fractional radiofrequency microneedling is a new technology. So our patient here demonstrates the effect of microneedling in skin rejuvenation. So the picture above here shows there are very visible atrophic scar, uneven skin tone, textural irregularities and dull skin. And the picture here shows a much even skin tone, brighter skin, and the atrophic scar appear less obvious. The next one would be chemical peels. So chemical peels basically addresses pigmentation and promotes skin renewal. It is a method to cause a chemical ablation to induce an even and tight skin as a result of the regeneration and repair mechanisms after the inflammation of the epidermis and dermis. Chemical peel can be further divided into superficial, medium depth, and deep peel. Superficial peel penetrates the stratum corneum down to the epidermis, so it penetrates the whole layer of the epidermis. So examples of superficial peels would be alpha-beta lipohydroxy acid, such as salicylic acid, or TCA 10 to 30%. For medium depth peel, it penetrates through to the upper dermis, especially over the area of reticular dermis. Okay, and the examples would be TCA above 30 to 50%. The final one would be a deep peel. A deep peel basically penetrates through to the mid-dermis. So examples would be a TCA of more than 50% or phenol. So this is a patient who had several sessions of chemical peel. So on the left here, you can see epidermal pigmentation. These are called lentigines, all right? And you can also see here there are fine wrinkles as well, especially over the periorbital region, uneven skin tone and dullness. But after several sessions of chemical peeling, there is a marked improvement in pigmentation, smoother, more radiant skin, and tightening of the skin as well. This is one of my patients who've had melasma. Melasma, and I'm sure all of you also experience among your patients as well. Melasma is a hormonally influenced disease. It is much more prevalent in patients who are post-menopause, but we also see among patients who are pregnant as well. The thing about melasma is that it can be quite resistant to treatment. So the patient typically will present with brown to blackish dyspigmentation, especially involving the cheeks, the nose, the upper lip, and even the lower lip. Okay? The treatment is usually a combination of oral, topical, and physical treatment. The first line of treatment for melasma is chemical peel, not laser. So you can see the improvement in these patients after several sessions of glycolic acid, 20%. So the melasma appear much less, the patient has a much brighter complexion. So the next treatment which I'm excited about is energy-based device. So laser and light therapies is widely used among patients who are post-menopause in my setting. It basically treats dyspigmentation, wrinkles, and stimulates collagen. So there are various types of lasers. Vascular and pigment irregularities can be treated by lasers emitting light between 532 to 1064 nanometer wavelength. If we target the intracellular water, that is usually by using lasers emitting wavelength between 1320 to 1540 nanometer. Whereas for pulse dye laser or PDL laser, it targets the dermal and subcutaneous senescence. Fractionated CO2, erbium glass, or erbium yak laser cause re-epithelialization and dermal remodeling. So it's good to treat fine wrinkles as well. The other thing about energy-based device is monopolar RF or radio frequency. which is a non-invasive way to obtain skin tightening and immediate collagen contraction. So this patient basically presents with a very large patch of lentigine. This is a bit rare because lentigine is usually macules. They are smaller in presentation, but this can happen. So it's a large patch of brown dyspigmentation at the tip of the nose. Okay. Firstly, we've treated the patient with CO2 laser by epidermal resurfacing, and then followed by pico laser to target the micropigments. The reason why we are using pico laser because of the lesser downtime compared to other pigment lasers such as Q-switch. And this is the case of a large seborrheic keratosis. A seborrheic keratosis is a benign epidermal growth which usually present among elderly population. So it's quite common among postmenopausal women. A seborrheic keratosis appears to be a stuck-on appearance, as in this case, it's over the left eye. So the treatment for this would be by doing a CO2 laser, a layer resurfacing, okay, to ensure minimal side effect. So the next one would be a platelet-rich plasma. Platelet-rich plasma, or PRP, is an application which is widely used for skin rejuvenation and hair restoration. PRP is derived from fresh whole blood, which contains a high concentrations of platelets. Various growth factors are present in PRP, such as the platelet-derived growth factor, transforming growth factor, vascular endothelial growth factor, and insulin-like growth factor, which are secreted from the alpha granules of concentrated platelets activated by aggregation inducers. And the last treatment that we'll go through today would be PDO threads. PDO, or polydioxanone thread, is an absorbable polyester monofilament consisting of a very flexible polymer composed of para-dioxanone monomer, which is degraded in the body by simple hydrolysis. It acts as a neovascularization agent in collagen regeneration and as a degenerating agent of adipocytes. PDO threads is effective in the formation of collagen around the thread and improvement of the condition of the anti-aging factor through sagging skin, vascularization, and thinning of the superficial fat layer. So this patient, as you can see here, the post-menopause effect actually leads to jowling due to volume loss. You can actually see this marionette line increase in the nasolabial fold. After insertions of PDO threads, you can see here that the jawline contour is much more pronounced. The cheek is also more prominent. The nasolabial fold appear much less, and there is completely invisible marionette line. So the last one that I'll touch today is about combination therapies. A lot of studies nowadays have shown that if we were to combine treatment, especially of those of skin biorejuvenation or skin boosters, together with energy-based device, this can lead to a more comprehensive and even better results. So this is one of my patients where a combination of pigment laser, particularly pico laser, skin booster, which is the HA skin booster, as well as micro needling. So the picture on the left here, you can see multiple patches of brownish to black dyspigmentation. These are mainly lentigines, which are compounded by PIH, post-acne, post-inflammatory hyperpigmentation. There is also uneven skin tone and dull skin. After several combination treatment, you can see that all the pigmentations are basically resolved with an even brightening skin and a more rejuvenated look. And this patient here, actually, the patient does not have any visible problem, I would have to say. She mainly came for skin rejuvenation. So what we did was a pico laser several sessions together with chemical peeling. So you can also combine laser with chemical peeling during the same setting. So after several sessions, you can see that the skin appears to be glowy, brighter, and also fresher look as well. Okay, of course, with the treatment of aesthetic medicine, it requires maintenance. It's just not one-off. So after several sessions of intensive treatment, we normally ask the patient to come back after 2 months and to do regular treatment every 2 to 3 months. So what should we do then when we see a patient with aesthetic skin problems who come to us post-menopause? Firstly, what we normally do is we do a comprehensive patient assessment, evaluate their hormonal status, skin condition, and what are their goals. Secondly, we need to customize the treatment planning. We tailor the interventions to individual needs and concerns. We also need to do a proper education and counseling. We discuss realistic outcomes and, of course, post-treatment care. Post-treatment care is very important to prevent any side effects, especially post-inflammatory hyperpigmentation, which is quite prevalent among Malaysian patients because of our skin color. Collaborative care is needed. We work hand in hand with gynecologists, endocrinologists if needed, and of course, nutritionists. So as a conclusion, skin aging is largely affected by relative hypoestrogenemia in menopause, chronological age and sun exposure. Common skin concerns include volume loss, wrinkles, skin dryness, and alopecia. Treatment needs to be customized according to the patient's need. With that, I thank you. I welcome any question.
Thank you very much for that very informative presentation. Could you elaborate a little bit more on the complementary modalities of treatment, like looking into nutrition, the level of exercise, as well as in patients who are undergoing this, and the use of other cosmeceuticals that can be used?
Sorry, can you repeat the question?
Yeah, about other complementary modalities, that about how you look after their nutrition, how you look after their level of exercise, that may complement the treatments that you offer in them.
What are the other treatment modalities?
Yeah, basically the lifestyle modifications that...
Oh, I see, alright. So the other thing about treatment with aesthetic medicine for postmenopausal is, of course, we do encourage nutraceutical, which is basically supplements. I'll touch on skincare in a bit. I have 5 more minutes to go. So with regards to cosmeceutical products, the supplement which is approved by the FDA USA for aesthetic medicine would be an antioxidant such as Heliocare. Have you all heard about Heliocare before? So it's actually an oral sunblock. It's made from Polypodium leucotomus. It's from fern. So it's good in terms of skin rejuvenation. It's also good for sun protection as well. So we always advise them to take some antioxidants. But of course, antioxidants can also be present in other forms, like for example from pomegranate itself, or even from glutathione, but make sure that they are all licensed, okay? Because we have to make sure that the dose is correct. If not, it can impact other systems of the body. Okay, in terms of skincare, the 3 main ones that I normally advise, so it's in the guideline. What's needed is actually to clean, so cleansing. Second one is to moisturize, because we know hydration is one of the things which is largely impacted post-menopause due to the hypoestrogenemia. And finally is, of course, sunblock. The thing about all these 3 treatments is that it needs to be tailored according to the patient. One treatment cannot suit everyone. So normally for cleansing purposes, we always advise them to go for the gentle cleanser first. For those who have a dry skin, we normally advise those cleanser rich with ceramide. Same goes for the moisturizer as well. Patient normally will ask us, is it okay to combine this moisturizer with some serum or even toner? The answer, it depends on the skin. bear in mind when the patient has dry skin, they are often prone to have allergic contact dermatitis. So using harsh product like toner or serum can exacerbate this condition. So what we normally tell them is before you try any product, you can, some whitening agent can help with all those irregularities on the skin. Like some contains HA, some contains histamine, and some contains vitamin C and so forth. But before, especially for those who are post-menopause, I normally advise them to do a simple patch test on the skin first. That is basically to apply the particular moisturizer on the skin, leave it for the whole day, and do it every day for 7 days. If there is no reaction, then likely there is no allergic reaction. So they can go on and apply on the face, but still they have to be on the watch out in case any inflammation arises. And lastly is sunblock. With sunblock, the weather here I realize is very much similar to Malaysia. So we normally advise them to put the sunblock every 2 to 4 hours. That's according to the Australian guideline. So every 2 to 4 hours using oral sunblock with an SPF of 30 at least. If the patient has a condition before which is due to sun exposure, like for example they have these lentigines or they have certain condition like seborrheic keratosis like I've shown earlier, then the SPF should be higher, which is SPF 50. That's it.
Any further questions that you may be having? Do you have any experience in using adipose tissue derived stem cells in this aspect?
I see. All right. We work hand in hand with our plastic surgeons. He uses a lot of adipose tissue stem cells. I particularly like myself with stem cells. I use it a lot for androgenic alopecia for my patients.
Any questions from the audience?
In the absence of any further questions, we would wind up this session. And we are immensely thankful to Dr. Sayasri for her very informative lecture, and to present her with the certificate of attendance as well as appreciation. I would like to invite our social activities of the Menopausal Side of Sri Lanka, Dr. Shamali Isanayakan.
Thank you so much. The chairpersons will now award the certificate to the speaker, and I'd like to cordially invite Dr. Dasanthi Akbimana to award the certificates to the chairperson. Thank you, madam. We are ready to move on.